So we've all learned the multiple ways that we can do stress tests for the ankle, as far as looking at the anterior talofibular ligament, calcaneal fibular ligament, etc. Those are really good tests to do for stability for the patient. Recent research in the clinical practice guidelines also has shown a reverse anterior lateral drawer test. Traditionally in NIOMP teaching, we've done the drawer test if it was an acute ankle, keeping it in a neutral position and pulling forwards or pushing backwards to look to see if there's increased mobility. In an acute ankle sprain, you also would first start with your screening, observation, and palpation for the Ottawa ankle rules, making sure they're not tender here behind the fibula, tender over where the navicular is, etc. Then what we typically did in NIOMP for a chronic ankle is bring them into full plantar flexion and push back, and full dorsiflexion and pull forward to look for stability of the mortise and any chronic ligament sprains. What they found in the research, in the recent clinical practice guidelines, is that this reverse ATFL or reverse drawer test, they used to do it like this and pulling forward. You've probably seen that. If you take the calcaneus and get it set, plantar flex about 15 degrees, because that's going to actually put that stress on the ATFL, just like we've done with our traditional ATFL stress testing. Then what you'll do is palpate right in that sinus tarsi, and I'm going to move my finger away so that you can see his motion. So he sprained his ankle, how long ago? 7 years ago. So he has a chronic ATFL. So I would grade, so they grade at 0, 1, 2, 3, 4. 0 is going from no motion up to significant motion. So he'd be at least a 3 on this. So that means we're going to have to really work on maybe him having some light bracing, improve neuromuscular control, make sure his foot mechanics and subtalar joint are moving appropriately, and then teaching him appropriate heel strike push off, stride length, etc., to make sure that he's not going to be beating on this and working on some of his weight-bearing proprioception. So that is the reverse anterior drawer test, which has had, the reason why they're choosing it, it has really good sensitivity and specificity simultaneously. So that is a slight modification, but it has really good utility in the clinic and functional application as well. So we're going to look at motion assessment of the subtalar joint. When we're looking at the subtalar joint, a lot of common errors is that you're trying to look at subtalar eversion with the foot in this position. Because of the plane of the joint, you have to roll out to about 45 degrees. You get your thenar eminence just under the sustenaculum tali, so that, and then your hand here is above the fibula. When you're working on the subtalar joint, this hand is doing a radial deviation. So what you'll do is you'll evert to the barrier, and then it's almost like you shift your body to see if you can get more eversion. There's 2 ligaments in the subtalar joint, and the posterior ligament has a lot of elasticity. It's energy storage. So if you don't have this eversion, then you're not getting that energy storage as you're trying to wind up your foot for push-off and gait. If we compare the subtalar joints on both sides, again, 45 degrees above the fibula, cupping the calcaneus. You evert to the barrier, and then you try to see the motion. And this one actually feels stiffer than the other one. Standing weight-bearing tests, that rotational test, you'll look behind. So let's have you stand up and face this way. If we do the standing rotation test, again, look at his structural assessment. Bring your feet together. He's not going to win flexibility contests significantly, so he's a little bit stiffer. So go ahead and widen your feet a little bit. And let's have you rotate to the right for me. And when he rotates, you're looking to see if he has more inversion here, so the angle will increase, and if he'll flatten out there. So come straight again. Sometimes if I can't figure it out, I'll palpate the neck of the talus and be on the calcaneus and go ahead and twist. So I can see if I can feel that inversion, eversion, and come back. And twist. And come back. And twist the other way. And come back. Twist the other way. And you can compare, and we can actually feel more motion here than in this joint. So that means we'll do a subtalar manipulation.